Welcome to Zooming Through ID series. I'm Dr. Gopal. I'm one of the infectious disease specialists who trained at Duke University. I've been practicing in South Florida in the Broward area for almost 20 years. Broward system is one of the largest system in the country. There are 4 hospitals: Broward Medical Center, Broward North, Broward Health Coral Spring, and Imperial Point. I chair the antibiotic stewardship for the district, and I'm also the chair for infection control medical director. I am the APD for the Infectious Disease Fellowship at Broward Health North. I do teach internal medicine residents. I'm a faculty for infectious disease. When the internal medicine residents rotate with me, uh, they pick a topic of their interest, um, and they research about the topic. Zooming through ID is an opportunity that gives them to showcase what they have learned. Today, I have Dr. Eduardo Sanchez here. Hi.
Good evening, guys. My name is Dr. Eduardo Sanchez, as mentioned by Dr. Gopal. I'm one of the first-year internal medicine residents here at Broward Health North, soon to be a PGY2. And I'm happy to be sharing this presentation to you guys. It's going to be a rather sweet and short introduction to tick-borne diseases.
Wonderful.
Okay, and if we're all ready, I will start sharing my screen. Okay, all right. Okay, can you see my screen, Dr. Gopal, with the
Yes, yes.
presentation?
Perfect. Yeah, I can see it.
You see the presentation all perfect up? Okay.
Yes.
All right. So let's get started. My name is Benjamin Eduardo Sanchez, and this is going to be a short introduction to tick-borne diseases within the United States, particularly given this is where we're practicing. The main reason why I think this is important for residents, physicians, infectious disease fellows, attendings, and generally anybody who's practicing medicine is just how quickly the number of cases of tick-borne diseases are being reported and documented within the United States. As you can see in the bottom right of the chart, the total number of cases has been steadily going up year by year. And not only that, 77% of the vector-borne diseases in the United States are transmitted by ticks. So out of all the diseases that could be transmitted by ticks, fleas, and mosquitoes, 77% of all of those can be transmitted by ticks. And this is a very fast and quickly evolving field, with 11 new tick-borne pathogens being identified just in the United States since the 1980s. And this is a quite a bit of a problem that's been overlooked and kind of undertreated within the medical community, as a lot of these cases sometimes go unreported, as they can be mild, self-limiting, or it's hard to actually pinpoint which disease process it's going on, and some of these diseases are not ever reported. For example, the total number of actual Lyme disease, for example, cases is supposed to be 8 to 12 times more than the number of cases that are actually. So just the number of cases that we know about are probably only a fraction of the actual number of cases that occur within the United States. And of course, there's always the cost and morbidity associated with disease. Just for Lyme disease, there's some estimates that show that it costs the medical community and harbors a weight of around $1.3 billion in damages each year, and personal life and medical costs. Okay, so let's get started. And some of these diseases are reportable. Some of the new ones are not yet reportable to the CDC and your state government. So there's a list on the bottom, on the right, as I mentioned before. Lyme disease is the most common one. That's the one that we're going to likely most focus more on today. And as you can see, that usually the cases have been ranging between anywhere between the low 18, 20,000s to as high as 62,000 in 2022. And this is all coming from the CDC. Okay. So this is a quick breakdown showing all the different types of vectors that tick-borne diseases will transfer, which can then lead to a disease. Most of these diseases are going to be caused by bacteria, which amount to 82% of those diseases. And then we'll be going over each of the specific pathogens real quick after this slide. Most of them are going to be bacteria, and then lesser known are going to be less likely is going to be viruses causing the disease. And there's only one parasite known, which is Babesia at the very moment. There's also an unknown category, which is a new and developing disease called STARI, Southern Tick Associated Rash Illness, which is somewhat similar to Lyme disease, and we'll talk about that on further lectures. So this is another slide here that goes into deeper detail, detailing which of the pathogens are transmit which disease, and it goes into even greater detail, showing which vector actually transmits the disease. The most common ones you want to focus on for board practice purposes and clinical practice is going to be on the top left, showing Lyme disease, usually transmitted by Borrelia burgdorferi and other Borrelia species such as Mayoni. And their vector is the black-legged tick most often, and the western black-legged tick. We'll talk a little bit about identifying some of these vectors and what they look like on the very next slide. You can also see that the rest of the diseases also are transmitted by the black-leg tick for anaplasmosis, along with the other culprits being most commonly the Lone Star tick, the American dog tick, and the Rocky Mountain wooded tick being the biggest culprits for some of these diseases. The most common ones that you'll be asked about during wards, during your examinations, is going to be the black-legged tick transfers Lyme disease, and that the pathogen is Borrelia burgdorferi, which is a spirochete mechanism bacteria. So this is actually the most common tick vectors, and we'll talk about where some of these tick vectors are actually found within the United States. But you can see that they all kind of look somewhat similar unless you're an entomologist. And the most important part that I would take away from this slide, whether you're a student, a resident, an infectious disease fellow, is where these ticks can be found. Sometimes what time of the month or year some of these ticks can be found. For example, the black-legged tick, also known as the Ixodes scapularis, is usually around during spring, summer, and it's usually found in the Northeast, upper Midwest area. And a lot of board questions and clinical disease cases as well will have these correlations, as they will usually mention that a patient was out around that time during summer, or they come from the Northwest. They usually mention areas like Pennsylvania, New Hampshire, and some of these correlations can actually be very helpful and useful in helping pinpoint a diagnosis and seeing which kind of tick was actually the vector, and helping actually nail down which tick-borne disease you may or may not be dealing with. The other most important ones I want to know about are the Lone Star tick, Amblyomma americanum. This is usually in the eastern United States as well, but this is mostly found in the South, Florida, Texas, that sort of area, in comparison to the black-leg tick, which is in the northeastern United States. Sometimes you find a patient with actual ticks on them. These are actually somewhat very tiny. If you could kind of see, they're just on a pinpoint of a leaf on these pictures, and it might be difficult to identify which tick it is, even if you have one visibly with you, unless you might be an expert entomologist as well. Okay, this is the distribution of some of these tick-borne diseases, and this is probably yield information for board taking purposes and possibly for clinical practice besides actual management of some of these diseases. As you can tell on the Lyme disease, the purple area is very concentrated in the Northeast region, and most test questions And even patients that I have had with Lyme disease will say that they're from these areas that are highlighted in purple. Each one of the dots that's shown is representative of one actual reported disease case. And the conglomerate you can see in the northeast corner just very heavily implies the distribution of the Ixodes tick and the Borrelia burgdorferi spirochete that they are carrying. Spotted fever rickettsiosis is also in the eastern, but also a little bit more central and not usually as northeastern United States. Anaplasmosis also has a predisposition for the northeastern, midwestern area, along with babiosis. And there doesn't seem to be too much of a tularemia pattern. It seems similar to spotted fever rickettsiosis, although there's not as many cases of them reported to the CDC to make such a conclusion yet. So the disease that we're going to focus on mostly today, like I mentioned before, is Lyme disease. And in the United States, it's mostly caused by Borrelia burgdorferi, and as I mentioned, less commonly a different Borrelia species, Borrelia miyoni. It's something important to know about this organism for test-taking purposes is they're not very visible on gram stain. So a lot of questions you'll see noted, they say that this organism is not very visible on gram stain, very faintly visible, or not visible at all. As I mentioned, the Ixodes tick is the vector, and it is the most common tick-borne disease in both the United States and Europe. Another important pathophysiology to know about Lyme disease is that the Borrelia burgdorferi causes this Lyme disease not specifically by any toxins, proteases, or other molecules that could be forming it. It is mostly all an immune response and inflammatory components from the actual spirochete being within the human host that causes Lyme disease. There doesn't seem to be any toxins or any molecules that are activating any pathogenic process that we know of at the moment. It's mostly all inflammatory and autoimmune. On the top right, you could also see that same image that shows the Ixodes tick and what it looks like. It's super small when I've seen it on other pictures, and it might be difficult to even identify once you have it right in front of you. And then, as I mentioned before, the distribution is up in the northeastern parts of the United States mostly. This also right here is going to be the most high yield part for the clinical aspect, be detailing all the different possible manifestations and disease progress of early Lyme disease to late stage disease, along with the very characteristic and pathognomonic bullseye rash, also known as erythema migrans, that is so frequently shows up on shelf exams, board exams, and ABIMs, and as well possibly even internal medicine and infectious disease boards. So the common pattern that we'll usually see is the bullseye rash. That's the classic pattern with a central clearing. But upon review of many cases that I saw online of Lyme disease that were reported, can appear in a myriad of different ways, and it just don't get caught up if you see in real life that it may not always appear so classically with the bullseye rash, as I shown in the bottom left slide corner. Erythema migrans can have various appearances with disseminated lesions, the classic bullseye rash, blue and red lesions can coalesce together, or even a uniform red region. Going back to how Lyme disease progresses, usually we'll have early localized disease, where that's where you'll see the classic erythema migrans, and it happens only in about 80% of cases. So even though you may not see erythema migrans, does not mean you won't have Lyme disease. You can still not have erythema migrans in around 20% of cases. And then you'll have some non-specific symptoms such as fatigue, malaise, lethargy, mild headache, neck stiffness, myalgias, and arthralgias. Not very useful in making a very discrete diagnosis. Once you have early disseminated disease, you'll have a little bit more classic symptoms. So you could have the rare carditis, which is usually tested with the young kids having first degree AV block after playing outside for a couple of hours or so during the summertime. They could also develop cardiomyopathy or myoperdicarditis. Sometimes, rarely, you'll have neurologic manifestations, meningitis, neuropathy. Those are the most classic presentations. Sometimes, very rarely, you'll have myelitis or encephalitis. MSK and skin involvement are also pretty common. Lymphadenopathy is a regional or generalized. Sometimes you'll develop eye involvement with conjunctivitis and iritis as well. And you could also have liver and kidney disease, although those usually are not very commonly tested presentations. Late stage disease, that's usually months or years after being infected with the spirochete. You can continue to have musculoskeletal symptoms with arthritis, usually monoarthritis. Neurologic disease, not particularly well studied with an incidence that has not been established. And you could also continue to have peripheral neuropathies and encephalomyelitis. Cutaneous involvement has been described only in Europe with morpheal and localized scleroderma-like lesions, but I haven't seen, upon my review, many cases in the United States. Lab findings are also not very specific and may not help you nail down a diagnosis. You'll have elevated ESR, and that usually only happens around a quarter of the cases. Elevated creatine kinase in around 12%. Leukocytosis, leukopenia, anemia very rarely occur, less than 5%. And thrombocytopenia and transaminitis being the most common. Transaminitis around 37% of cases. Overall, nothing that might help you pinpoint down a specific Lyme diagnosis. So to actually make a diagnosis, you need to do quite a bit of detective work. And it makes it super easy if the patient actually does have erythema migrans rash. If you see a classic erythema migrans rash and the patient has been exposed to ticks in an endemic area, that's a clear-cut case. There's no further testing necessary. You can start therapy. However, if there's another diagnosis that could be equally valid for your suspicion of your patient's constellation of symptoms, you have to continue working that up on the other side. If there's no erythema migrans and you have a high clinical suspicion, you're going to need to do some lab work with enzyme immunoassay assays or fluorescence assay as well. So thankfully, I've been lucky enough to have one of these cases over here at Broward Health North. And if you look at the bottom right, this is actually how the results are going to look for a positive Lyme disease case. So to have a positive Lyme disease by IgM immunoblot, you need to have at least 2 to 3 specific Borrelia proteins. And if you're going to go by CDC criteria and you do an IgG immunoblot, you're going to need at least 5 of 10 specific Borrelia proteins. And when you order this lab, it's going to come back as a myriad of different sized proteins, IgM and IgG, as you can see at the bottom right. And they're all separated by the different size of these proteins as measured in the kilodaltons. And you're going to need at least 2 out of the 3 IgMs or 5 out of the 10 IgGs. As you can see at the bottom right, this patient in particular had all 3 IgMs and 1, 2, 3, 4, 5, 6, 7 different IgGs. So this patient definitely had Lyme disease, and it's pretty interesting to see how this results at your own practice. It may or may not look different. Just remember the criteria of 2 out of 3 IgMs and 5 out of 10 IgGs for the Borrelia proteins. Okay. So this chart right here is from up to date, and it tells you specifically how to treat Lyme disease based on its presentation, how far along you are in the disease course, as well as which how old the patient is, because that's actually one of the most commonly tested topics on USMLE exams. So generally, doxycycline is the first line agent. However, one of the common tested problems that you'll have on boards is that doxycycline can be harmful to patients' teeth, particularly if they're under 8 years old. And they're known to cause teeth discoloration, and they're also contraindicated in pregnant women. So generally, for patients who are under 8 years old, if you're able to look at the chart, you're going to want to go with amoxicillin on your exam if the patient is under 8 years old, or if the patient is pregnant as well. There's some specific circumstances that you'd want to know about in particular. So, for example, a patient that has very advanced neurologic disease, you're going to go with IV ceftriaxone. Or if the patient has severe heart block, not first degree heart block, severe heart block, high degree AV block, you're also going to want to go with IV ceftriaxone. So it's going to be 2 grams IV daily between 14 to 21 days for severe cases if you're going to do ceftriaxone. If it's just a regular run-of-the-mill early disease, first degree heart block, or erythema migrans, you can get away with just doing doxycycline, usually for around 10 days, twice a day, 100 milligrams. If there's further involvement in neurologic disease, but it's not severe, you're going to need to extend that course up from between 14 days to 21 days. But for board taking purposes and clinical purposes, you're going to want to remember it's going to be doxy first. If they're under 8 years old or they're pregnant, you're going to go with amoxicillin. If there's severe neurologic disease or severe AV block requiring AV pacing with high degree heart block, you're going to want to go with IV ceftriaxone. So, funnily enough, this is a syndrome I came across during my studies. There's actually a post-treatment Lyme disease syndrome where a patient can continue to have nonspecific malaise, fatigue, constitutional symptoms after being treated with Lyme disease. This is actually a mix-up question regarding this disease, and you're just going to want to continue supportive care, treat the patient symptomatically, supportive care, continue to have serial evaluations, and there's no evidence to continue treating Lyme disease with this syndrome, but I believe this is still an evolving field. Okay. So another part that we're always focused on treatment, prevention and prophylaxis. You know, an ounce of cure is worth like a pound of prevention, or however the saying goes. You're going to really want to know how to prevent and prophylax against these pathogens if you're in one of these areas. So the most important part is always avoid them if possible. Know where to expect the ticks. It's going to be tall, grassy areas, bushy, wooded areas. If you're going camping, if you're going outdoors in these areas, you're going to want to know that you might be exposed. It's always in cabins. It's always in the Northeast. And that if you are, there's actually some agents that you are able to use, such as DEET containing, picaridin containing, or lemon of eucalyptus containing products. So these are usually sprays, and they help prevent bugs, mosquitoes, ticks, and just be able to make sure that you have good coverage, good clothing. You're going to want to cover your feet with some good boots and wear long sleeves if you can. And then after having a day out, always make sure you do yourself a check and make sure that you don't have any ticks at the end of the day on you. The problem starts if some of these ticks are on you for around more than 12 hours. That's when you're going to have to start seeing issues. So make sure that you are able to check yourself and take some precautions if you know that you're going to be out in some of these areas. So this is going to be a little bit of a quick review about taking some board exam questions specifically for Lyme disease. A lot of this was mentioned earlier, but I just really want to drill this in because you will get a question about this during any board exam you're going to take. I've gotten questions about this on step 1, step 2, Comlex 1, Comlex 2, and I just took Comlex 3. Yeah, I also got a question about this as well. It's super high yield. I had a patient with this during the wards as well. So you're going to want to know a lot about this. Your attendings are definitely going to ask you if nobody else does. So specifically for Lyme disease, as I mentioned before, want to know if they mention in the stem of the question, was the patient outside? Were they in a forested wooded area? Did they say they were playing and outside in the grass or in the forest or in the hills nearby? If they mention erythema migrans, that's a slam dunk. But a lot of test takers are trying to get away from this because they know that we're looking out for this question, high yield buzzword in the stem. So just be on the lookout for it. Easy points if you can see that. If it's not mentioned for it, don't rule it out of your differential. Another part as mentioned before, commonly tested side effect for doxy in young children and pregnant women is teeth discoloration, and also possibly affect bone growth, but most commonly tested, it's going to be teeth discoloration. Also, when you're trying to ask yourself, well, you need to ask yourself, what am I going to treat this patient with? Always ask yourself two questions, as I mentioned before. Who's your patient population? Are they young? Are they old? Is it a man or a woman that's pregnant? And how severe is the disease? Is it localized arthritis? Is it severe neurologic disease? Is it first degree AV block? Or is it third degree AV block requiring transcutaneous pacing and ICU admission? Those two questions right there are going to help you determine whether you're going to do just doxy or you're going to need to go with the IV ceftriaxone on board answers. And this last line right here is going to be super high yield. This question is asked very repeatedly
So, yeah.
on
So
exams all the time. It's
yeah.
going to be yes.
Hi, this is great. I think we will pause and I will add some more, some clinical pearls. This was wonderful, Eduardo. You finished, you pretty much covered a lot of topics. So just in terms of the clinical presentation, as you mentioned, the 70% of the, cases, there will be erythema migrans. You need to remember about facial palsy. You can get cranial nerve 7 palsy and bilateral cranial nerve palsy. It could be Lyme, or the other thing to think about is sarcoid. Lyme arthritis, you touched up on that. I mean, we see that about 29, about 30% of the cases would be arthritis and then carditis. So a point about carditis. So if you might get a case where there is a complete heart block, and then the cardiologist want to put a permanent pacemaker. So you will have to, if it is Lyme case, we don't need a permanent pacemaker. Usually with treatment, they get better. So that is one point I have to make. Arthritis, if you tap the joint, the WBC count would be around 10 to 25,000, and it will be predominantly neutrophils. Serological testing is really good. 100% sensitivity. If it is an endemic case, if you rule out other conditions for arthritis, and serology is pretty good. In terms of the diagnosis, there is I know you touched up on that, and that is great. The two-tier testing, the ELISA, and then you have to do the Western blot, and you did all of those. And there is a new modified two-tier testing where they do two ELISAs. The first is a EIA ELISA, and the second one, I know that you briefly talked about it, the C6. That basically that is also an EIA. And basically, they test the proteins in the Borrelia outer membrane, and it's a little bit more specific. Mm, the other point I want to make is erythema migrans. I mean, like you mentioned, we don't need to do any serology because they probably won't mount a serological response. So if they are from, say, New England, Mid-Atlantic, or Upper Midwest, and if there is a tick bite, then clinically we can diagnose that. Um, some of the case scenarios we see that a patient may come in from the community, they would think it is cellulitis and start treatment with Keflex or Bactrim. So the Keflex, there is it does not treat Borrelia. So it's a first generation cephalosporin. So only second generation cephalosporin will be active against Borrelia. So that will be, it will be a misdiagnosis. Erythema migrans, it may be sometimes a flat. It may not be always bullseye, like you mentioned. And if they give them Keflex, they won't respond. Okay, I think you have a couple of more questions, right?
Yes, yes. So thank you
Yeah.
for those.
And then always we have to think about co-infections, Lyme and Babesia, if it is, if it is a possibility. And then if they find a tick, sometimes they give a scenario where there is a tick and there is intense itching. So that could be just a hypersensitivity reaction. It may not be, the tick is not attached too long, then it could be just a tick hypersensitivity reaction. Again, if it is not in an endemic area, then we don't need to give them doxycycline. But if the tick is attached, almost a long time, like about less than 72 hours, and if it is an endemic area, we can give them like 1 dose of doxy to prevent. And I think you talked already about the late Lyme and ceftriaxone treatment. Yeah, I think that's all done.
Awesome. Thank you for those clinical pearls. Those are all great for actual clinical practice, as once you're like in the wards talking with the intensivist and making sure you perform the best care for the patient.
And
Definitely.
I'm glad you found the post-treatment Lyme disease syndrome. It is about 10 to 12% of patients will have that, and there is no utility. There's more and more studies saying that there's no utility for continued antibiotic treatment in them. These are more chronic fatigue patients, and it is a new evolving entity, but not a whole lot of utility in continued treatment. And the other aspect is once serology is positive, we don't need to continue treating. The serology may remain positive for years, so we don't need to continually treat them. That's also another point I want to make it. Yeah.
Perfect. And thank you for that. We'll definitely have to keep in mind those things once you're actually practicing. I did have that same scenario come up with one of my patients where cardiologist was like for a pacer, and they only required transcutaneous pacing while they were getting Rocephin treatment, and their AV block improved dramatically overnight once they started on
wonderful
proper regimen. So as Dr. Gopal mentioned, and I was trying to get to on my previous slide, the most common presentations you're going to see on board exams, it's going to be the young child who was playing outside and they developed a first degree AV block. That's going to be so high yield. Mm-hmm. I've seen that question 2 or 3 times on different board exams. The other one that you're going to see, as Dr. Gopal mentioned, it's going to be an adult with Bell's palsy, that cranial 7 nerve palsy. You're going to want to think, hey, that could be Lyme. So those are the 2 common clinical tested presentations that I'd be in mind. The other one would just be somebody with a rash and erythema migrans after they were somewhere in a high endemic area. Mm-hmm. So without any further delay, let's jump into these 3 board questions that I've had prepared for you guys. These are coming straight from MixApp, coming from board review, and with just a minor adjustment. And hopefully these will help you prepare for some of your endeavors. So let's get started. We're going to have to do 3 quick questions. Question 1, it's detailing about a 68-year-old man evaluated for onset of mild pain and significant with swelling of his left knee. He lives in Eastern Pennsylvania as an avid golfer. So he had an illness characterized by enlarging erythematous annular skin lesion in the left popliteal fossa associated with fever, arthralgia, myalgia that spontaneously resolved after several days. On physical examination, vital signs are normal. Joint examination shows diffuse swelling of the left knee with minimal warmth but no erythema, slight flexion of the left knee but pain-free range of motion, and a popliteal cyst. Results for serologic testing are positive for Borrelia burgdorferi. Okay, so the question is, what else could you expect to see in this patient? And I may have just let it go there after clicking inadvertently. And some of these other answer choices here, you're going to want to think about what's going on right now. This question was very generous, and they were more than generous enough to actually let you know that the diagnosis is Borrelia burgdorferi. And as I mentioned before, one of the most common things you're going to have is carditis with AV heart block, usually first degree AV heart block. Hilar adenopathy, you're going to want to think more of like sarcoid or other disease processes. Nephritis, you're talking about lupus or some other nephritic syndrome. Proximal muscle weakness, usually associated with some other type of myopathy or autoimmune disorders. And subungular hemorrhages, that's referencing one of the possible symptoms of endocarditis, usually infective endocarditis. So don't get swayed by some of the answer choices. Always ask yourself, what's the disease process? What are the symptoms? What are they asking me for?
So we have 2 minutes.
And as I mentioned before, AV heart.
We have 2 minutes left. So let's, zoom through those 2 questions.
Next question is a 40-year-old man seen in early September for right facial nerve palsy, 2 days duration. His initial evaluation in the emergency department included Lyme serology. Treatment was deferred pending results. He's a landscaper in Rhode Island. Other medical history is unremarkable. On exam, he has a right-sided peripheral 7th cranial nerve palsy. The remainder of his neurologic examination is normal. No rash is present. Enzyme is positive for Borrelia burgdorferi. IgM, moisture in blood, is also positive, and so is IgG. So here it's asking, what's the treatment of choice? What do you want to do for this patient? And as we mentioned previously, you're going to want to think about, is it B or is it D? Is it doxy or is it ceftriaxone? And this patient symptoms don't appear to be severe carditis or severe neurologic disease. So we're going to go with doxycycline. Always remember those 2 answers. Okay. Question 3, and the last one, is going to be a 43-year-old man who's being evaluated in the emergency department for 1-day history of left facial weakness following 10 days of headache, stiff neck, photophobia, and he reports no sick contacts. He's a park ranger in Pennsylvania. He takes ibuprofen for headaches. He has a temperature 101. His left facial cranial nerve palsy. He also has CSF studies showing leukocyte count of 95, glucose of 56, and a protein of 76. And now they're just asking us what the diagnosis is. And you guys should already know, given the facial palsy and the meningitis type symptoms, we're going to go with Borrelia burgdorferi. And these are my references.
It was excellent presentation. Wonderful.
Thank you, Dr. Gopal, and thank you to anybody who watches this video in the future.